Good afternoon, everyone, and welcome to this oral evidence session of the Welsh Affairs Committee. My name is Ruth Jones, and I'm chair of the committee. And I'm really delighted today that we're going to be joined, as well as our witnesses, we're going to be joined today by Russell George, who is chair of the Senedd Health and Social Care Committee. And we're really pleased to be working with our Senedd colleagues on this, and we're very grateful to Russell for coming along in person today. Thank you. We know that healthcare is very important to the lives of all our constituents, and accessing healthcare across the border with England is a reality for many people in Wales. So today's session is going to focus on what works well, but also how cross-border healthcare could work better for patients across Wales and for communities on both sides of the border. On our first panel today, we are joined by Rachel Power, Dr. David Bailey and Dr. Stephen Kelly. On behalf of the committee, thank you so much for coming in today in person to be with us. We're really delighted to have you with us. So what we're going to do, we've got 3/4 of an hour, so we've got a lot to get through. If it's all right, I'm going to make a plea for some short questions and short answers. To the point. Before I introduce the witnesses, I'll ask them to introduce themselves. I'm just going to check for members' declaration of interest. None. Lovely, thank you very much. Could I begin by asking the witnesses to introduce yourselves very briefly? If I start with Rachel Power, please.
Hello, thank you for inviting me today. My name's Rachel, I'm the Chief Executive of the Patients Association. We're a very small national charity that work directly with patients, but we're non-disease and non-condition specific, and we hear from patients through our helpline, our free phone helpline, our focus group and our survey work.
Thank you. Dr. Kelly.
My name's Stephen Kelly. I'm a consultant in Wrekin Minor Hospital. I'm a respiratory consultant. Still croaky voice, it's how it saves us. I'm also chair of the Welsh Consultants Committee.
Hi, I'm David Bailey. I'm a recently retired GP and the immediate past chair of Welsh Council of the BMA.
Brilliant, thank you very much. If I can begin, I suppose there's a general question. If I ask Rachel Power first, do the current cross-border healthcare arrangements work for patients? And if they don't, how could we improve that experience?
That's quite a big question. In all experiences, what we hear from patients is that once they get to their healthcare professional, the relationship's really good and there is trust and confidence. It's everything around that can cause a level of frustration. And the impact that waiting and not knowing what's happening and lack of communication that can have on patients' ability to get on with their lives, to go to work, the mental health impact it has when you're sometimes waiting for something and not knowing what's happening. So I think for me there are areas that really need addressing, and I think the first one is what we hear quite often is the lack of the integrated electronic healthcare record, patients having to repeat themselves, having to go for different tests in different parts of between Wales and England, and the impact that has, and of course that unnecessary repetitive of tests, which can have real impact on your mental health if you're worried about something quite serious. But for the country, Wales and England, the cost that can have, and the kind of coordination and continuity of care that can happen across borders. I think the other thing that I'd like to raise now, and not go on for too long, is the impact that can have on patients with, and especially if you think of areas around Powys where there is no district hospital, and the reliance on English facilities, patients are left with complex journeys. We just did a piece of work on health inequalities around cancer and blood disorders, and we spoke to one person who talked about £150 to get to a hospital appointment. And the impact that was a choice between food and going to a hospital appointment, but also the location of centres in areas that are accessible to public transport is really important, because you can have accessible healthcare, but it may not be accessible. So one patient described being able to get to the appointment, but the bus would get them home 2 days later at the time of the appointment. So I think we need to think about that as well. We hear, and we were very grateful to Claes, which I hope I'm pronouncing properly, and to the RCGP in Wales, and we heard a lot about the impact of first Welsh speakers, and what happens when they're receiving treatment, where they're not getting the interpretation that they need, or that Welsh is not available. It means, and that is especially more for people with mental health illnesses and especially around the areas of dementia, if they're not culturally in their area, and that the impact that can have on them. And I am coming to the end. Obviously, the bit for me, and you know, this is true of integrated care systems in England as well as cross-border care. The truth is that the communication is not great. The communication between services about patients, the involving patients in communication, keeping patients up to date about what's happening. And when things go wrong, and we hear this through our helpline quite a lot, is that, you know, there are different systems for complaints management, and quite often, you know, in certain cases, we've got to remember and think about inequalities and think of English as second languages, and across the board, a lot of people sometimes, especially on the borders and some of the more newer the new housing developments, aren't sure whether they're in Wales or England when they're actually receiving treatment. So when something goes wrong, they find themselves stuck between the complexity of two different systems. So I think they are the issues that we're hearing at the moment from patients.
Thank you, Ms. Fenn. You've articulated the issues very clearly there. I'm going to bring in my colleague Claire Hughes.
Thank you, Chair. This question is also to Rachel Power. So obviously Wales and England have quite different populations and different healthcare policies. So what impact would you say that these differences have on patients who are accessing services across the border?
So the Patient Association is all about patient partnership and design and delivery of services and shared decision making in the way that we undertake individual consultations. So I think the impact, especially for Welsh residents coming into England, is sometimes there's a lack of knowledge about the services and how the services work. There's a lack of knowledge about how the services are commissioned. Up to probably the pandemic, and seemingly the BBC News has got better at explaining in Wales that it is an English development, not a Welsh development, that sometimes there's a confusion about where funding is going to happen, especially for more specialised care, where the funding is going to come from, even though there are protocols and there are funding protocols and there's partnerships. But like everything, sometimes those fall in the middle and the patient is left trying to find their way around it. I think the main thing for me as well is that I don't think the patients who are coming across the border are often involved in design and delivery and that feedback loop about actually what's going to work for them as patients.
How do you think that these problems could be best improved? Like what could be done?
I think it's about each system recognising the patients that they're working with. And where those patients are coming from, because I think this does come across the whole inequalities lens as well, that we need to work with patients to understand what services are going to work well for them. And we've done a lot around patient partnership, and you realise that if you are, you know, and I think there's a lot about commissioning for outcomes. So rather than commissioning for activities, I think there's something about looking and saying, actually, we're commissioning the service for outcomes and we're going to get patient experience and we're going to work with that patient experience and getting patient experience when it's good and when it's bad, and making sure there's real interconnectability between systems across Wales and England.
Thank you.
Very much. Andrew Ranger, please.
Thank you, Chair, and welcome all. This is to Dr. David Bailey, if I may. Obviously, we're seeing big challenges in terms of staffing shortages across the NHS, across the whole of the UK, including with GPs. So in terms of the performers lists that we obviously have two of, would having one list across both Wales and England, rather than the separate ones, make a difference to medical professionals travelling between Wales and England? And would that help simplify the cross-border complexities that we're seeing and improve delivery?
Up to a point is the answer. I mean, there are about 1 million people that live along the border, so there are a lot of doctors who would quite like to, particularly peripatetic doctors, who'd like to practice on both sides. And at the moment, we've got two separate lists. They both do the same thing. Both English GPs and Welsh GPs would be quite happy to combine them. There is a small difficulty in that the English list allows non-specialist GPs onto the list, which Wales doesn't. But a lot of the sort of governance issues that were originally a problem maybe 10 years ago, where Wales was uncomfortable with actually joining them up, those have largely gone with sort of national provision. And yeah, we'd absolutely like to see that, particularly for out-of-hours care. A lot of out-of-hours care in Wales is provided by Shropshire. A lot of people work on both sides of the border. It would be very helpful if at the very least, even if we kept separate lists, the same criteria are applied and you could just apply two lists with one set of data. At the moment, you've got to go through the whole rigmarole twice, which is a barrier to people being flexible.
Thank you very much.
Russell, did you want to come in there?
Thank you, Chair. Thank you, Dr. Bailey, for your answer. So I think what you're saying is it would be preferable to have one performers list for both England and Wales, or a UK-wide list. What are the barriers to the government, either government, doing that, and how do you overcome that barrier?
Well, as I say, originally the barrier was that Wales had a more centralised one that we're all fairly comfortable with, and England was much more fragmented. That's largely been solved now. The only problem that I think both sides have still is the people who are admitted on, and doctors who aren't GP qualified, who are represented by the SAS committee, the BMA, are also not comfortable with this. They just want a medical performance list which has got GPs on it.
So what are the practical steps that either government or both governments need to take to overcome that?
I'm not sure there are many practical steps. All they have to do is actually agree that the criteria that you submit to the Welsh Health Board or to the English regions will be accepted by both medical performance lists. Bang. Thank you very much indeed. It's not that hard.
I think that's food for thought. Thank you very much. I'm going to move on to David Chadwick, please.
Thank you, Chair. Another question for Dr. David Bailey. The committee's 2015 report noted that having different IT systems in Wales and England has a real impact on patient care. And in your written submission, you tell us that there remain problems today. That's something that I see a lot of in my inbox. Just this week I had a constituent contact me to tell me about her late husband's experience of receiving cancer treatment at Hereford Hospital. He was receiving treatment there, and then he needed urgent emergency end-of-life care and was admitted to Neville Hall Hospital in Abergavenny, but the team in Neville Hall were unable to access his English hospital notes. So what's been the main barrier to developing a joint-up IT system, given this committee recommended it 10 years ago?
Yes.
What do you believe could be done to solve it? Does it simply come down to a lack of political will?
Some of it's lack of will, but some of it was technical. Given that England's much larger, it makes sense to everybody go onto the same spine to use that. And at the moment, GPs can communicate with hospitals perfectly electronically in Wales. They can do exactly the same in England. But if one of you is in Bristol and one of you is in Cardiff, it's hopeless. And that's because they just don't talk to each other. And the Welsh DCHW, I never remember the acronym, the Welsh IT committee, is trying to work towards joining up to the English spine, which would certainly make transfer of records. And there are 30,000 people who actually live in England and have a GP in Wales and vice versa, but probably 3 times that number that move every year. 10% of people transfer every year in a GP practice. So it's likely that there may be 50 or 100,000 people. And if they go across the border in either direction, you can't transfer. And I think we have to accept that has to be something that Wales piggybacks on to England for, and there are technical issues about doing that. The systems are identical. I use exactly the same system as GPs all over England. It's not incompatibilities there. The incompatibilities are the central spines. And so it does need government action. I think probably it needs Welsh action for this. But also there are issues in terms of getting records back down from hospitals and actually pushing them straight into the GP record, being able to access records quickly. And again, you can do that in England and in Wales perfectly well at local hospitals. But if you're in Hereford and you live in Ross-on-Wye or whatever, all of a sudden you can't do it. And we really do need to get some joined up thinking there. And I think that individual hospitals, the two hospital systems have to start talking together. We've got a fairly consistent national one in Wales. But until we do that, and until we actually have a spine that all GPs can talk to each other, and it's not just England and Wales, of course, that's probably the biggest issue, but it's equally important in Scotland and Northern Ireland. You can't transfer from Scotland to Northern Ireland to Wales to England either. And we have to be able to, because we can do it in a day in each individual nation, but it can take 8 or 10 weeks to go from country to country, and that's an unacceptable clinical risk.
Okay, thank you very much. Henry Tufnell, please.
Thank you. I just wanted to turn to Stephen about the issue of specialised treatment, and as a consultant, if you could sort of set out the steps that you would take in terms of if a patient needed specialist treatment in England, for example, whether that's to do with orthopaedics with the veterans or eyes in Bristol, if you could set out the steps that a consultant needed to take for those referrals.
So it depends. It very much depends on the specialty. So we have some links which are very well set up and extremely straightforward. We even have in North Wales. We even have, for example, cardiothoracic thoracic consultants who do clinics with us and then operate in England. So for some services, the setup is good. For others, it becomes more difficult. So I would say the majority of the time, it's relatively straightforward. You have knowledge of specialist services and you refer. If you come across a need to refer to a service that there isn't links, if you get to the point where you need to do the dreaded IPFR, the individual patient funding request, they are and my nightmare. They take a day, literally. They take hours and hours and hours to do, and that's very frustrating. And you may have some examples of where IPFRs have had to come into play and the difficulties then trying to access services. That said, for the majority, where the paths are clear, they can be okay. What isn't so clear is if you have patients who are on, for example, a waiting list in England, there seems a lack of transparency to, is that waiting list the same as the English patients? Is it different? Are they treated differently? And I think what I would say is there is transparency needed. We hear that there are differences, but I lack that evidence to present here. But I think transparency in that would be useful. Do Wales commission the same waiting list times as England, for example? And that remains unclear. And I think clarity on that for patients would be good. Going back to the original answer, I think it's very specific, depends on the service, but it can work quite well. In terms of trying to get information back, that works less well, tends to be paper-based, which is not the way forward.
Do you know why it would work well in certain circumstances and why not in others?
Because I think they're established pathways. So they're routes that patients go on a regular basis. So we have relationships with those specialties. They know us, we know them.
And does that vary across different health boards?
Probably is the answer. I suspect some health boards will be more slick than others. So yes, I suspect it does.
And Rachel, in terms of the patient experience, we've heard about I think you referenced the dreaded IPFR. I was wondering, I've had constituents that have had real issues in Pembrokeshire in terms of going through that process. I wonder whether you could speak to the patient experience.
What I do know from patients and in terms of the funding, we hear from patients about different health boards and what can be funded and what isn't funded within those health boards. So they're very much one of the recommendations that we would bring here would be that there needs to be clear protocols for cross-border and patient pathways, because if you are being treated in one area, and I heard this morning of a family with a baby, very specialist baby, and having to travel quite a lot of distance to have the test done, then finding out where they were going to find their results, who was going to fund it and where that funding was going to sit. So that adds a lot of pressure to patients to kind of try and work that out, especially if they're moving between health boards.
And just finally, Stephen, are patients at a disadvantage if you're living in Wales and going to England, or if you're living in England is there a disadvantage?
The answer to that is it, again, depends on your specialty. So going back to things like thoracic surgery, I would say no. If you're going for other more elective type care, Possibly, yes.
Can I phrase it slightly differently then? In terms, we talked about the different variations between health boards. Is it the same in respect of England in terms of the trusts? So you get those variations between the trusts referring it over to the Wales and the same?
The answer is I don't know, but I suspect it could be variation, yes, because it's not transparent. So I think having clarity on that so that we can see it as clinicians and the patients can see it would be useful. Then that question, it should be just open knowledge. It's not clear, I think it's hidden, which makes you suspicious that it is different.
Thank you for that. Anne Davis, please.
Yeah, I've got a follow-up really on specialism, if I can refer this to you, Dr. Kelly. A constituent of mine was sent to Bristol Clinic, not the eye hospital, in 2021, where a cataract operation went terribly wrong. His eye blew, resulting in inoperable damage to his cornea, retina and iris, and now he's lost the sight in one eye. My point is this really, that if we send patients over the border to clinics rather than to hospitals, there has to be a system where they have access to emergency treatment if something goes wrong within that clinic. His emergency treatment was go home, 2.5-hour drive back to West Wales and come back the following morning, again another 2.5 hours, or to go to a hotel for the evening, which didn't give him any medical treatment at all, any medical emergency treatment. Sorry. I'm just wondering what your thoughts were on this, really.
I guess that's the difficulty of commissioning services outside of your area, is when it goes well, it can be slick and it can be good. When it doesn't go well, where do you go? They're far away. If you go somewhere local, they may not have access to what has been done. That is the innate, sort of the basic problem of contracting out services in other areas. I guess the answer is try not to do that as much as you can. And if you do, you need very clear routes of where people turn. The difficulty is the distance is difficult to hide. If you need to either set something up locally, which tends not to happen because you've commissioned the service elsewhere. And I think by definition the distance is always going to be there. And if you have to go back, you have to go back. Yeah. That is the only real way around it, is not commission services too far away.
No, but my question is this really, shouldn't there, if you use clinics, there should be immediate access to hospitals, should there need to be, that's all,
We'd hope so.
Yeah, you would hope so.
Simon Hall, please.
I suppose to any of you really, is there an identifiable trend, let's say over the last 10 years or so, of referring patients to English providers? And if the trend is upwards, is that a unwillingness of clinicians to practice in Wales, or a antipathy towards geographical specialisms rather than trying to be generalists across the piece?
By and large, the referral rules are different in England and Wales. Health boards commission a service for cardiology, hepatology, whatever, from a particular hospital, and by and large you have to refer into that hospital, whereas in England, of course, you have choice. The fact is that 95% of patients want to go to their closest proper hospital. So by and large, that doesn't cause a huge problem. But it is much more difficult to refer elsewhere if you have any particular reason from where the health board in Wales actually commissions a given service. And they can commission from different hospitals, but they do tend to commission for that particular health board. So your level of choice is significantly reduced.
I'll go back to Anne Davis, please.
I just sort of from the sort of patient perspective.
Sorry, I don't think that we have seen or have the evidence to say that there's been a bigger impact, but I think you're completely right in the sense that in England there is more choice and patient choice, and that might, but we would have to look into that in a lot more detail to make that a firm indication.
Is that something you might be able to write to the committee
I'll have a look and see what we can find for you, yeah.
That would be, I think, helpful. Thank you. And Dr. Kelly, did you have an observation on that?
I was going to say, I don't think there's been that much change. There are some services which aren't across the border. For say, one I think of in my region is specialist services for premature babies, which has very, having been in that situation a good while ago now, that must be extremely difficult for patients where their young baby is a long way away, especially if they've got other children. So it might make sense on paper to commission services because you might struggle to have the staff or the specialists, but actually the impact on patients and families can be enormous.
And I think we've seen that in a lot of care, both within England and Wales, in that sometimes, especially if you look at the getting it right first time principles, you know, for more specialist care, you are going to maybe have to commission further away because it's a more expert place. But then in the work that we did around health inequalities, around cancers and blood disorders, and there really needs to be something about how we look at people's schemes for helping people travel and allow their loved ones to be with them, because actually that is part of well-being and it's part of that holistic approach of looking at a young child or an elderly person who's travelling and waiting for treatment. They need to know that their loved ones can be close to them, and that has to be brought into the equation around outcomes.
I'm going to go back to Anne Davis now.
You mentioned this, Mrs Power, in your opening comments. Welsh patients receiving care in England may be Welsh speakers, and is there more that can be done really to look after their linguistic needs, especially, as you mentioned, you know, people who have dementia or perhaps young children really as well. And we realise that the Welsh Language Act doesn't apply, of course, to England, but the matter of equality and the Equality Act does everywhere. So I was just wondering what your thoughts were on that, really.
When I think about shared decision making and patient and working with patients and healthcare professionals, I think that the clear, you know, we are people beyond our conditions and our diseases, and we need to know how we're going to work with that person and what really matters most to them. So, you know, I feel that, and again, with the Welsh language, if it is a first Welsh speaker, then actually hospitals being commissioned or patients coming in for treatment within England have to arrange to ensure that there is clear interpretation, and we shouldn't be relying on families. This needs to be professional interpretation and translation services available so that people. But then I think there's something more about the cultural thing, because if you are thinking about dementia, it's about being able to get radio, TV, things like that, and I think that has to become part of the equation as well when we're working cross-border.
Thank you.
I'll add one thing on the Welsh language. One thing I would say is that looking at provision for the learning Welsh language is also an issue. So I did many years of Welsh learning. My wife became fluent doing the same classes. I should have done my homework and been better. But what I do find is, but I do understand a lot, but what I did find is that because my course was not quite next to the hospital, I had to fund it myself. Whereas I was at the same time with people who'd worked for local councils who were released and given time to do that. So I think there is more serious consideration to people who properly want to become Welsh learners and fluent speakers needs to be provided, because there are too many sort of, I'm going to meet and greet and have a few words of Welsh type courses which are not helpful, but it's be much better for the small number of people that really want to learn Welsh to be able to do that. Obviously we have things like in North Wales the Bangor Medical School, which will probably get more people locally to stay and will help Welsh language, you'd hopeful as well. But I think more serious attention to actually properly supporting Welsh people who want to learn Welsh in hospitals would be something I would like to see, because I think it is lacking.
Fantastic to hear, thank you.
Yeah, thank you. And I'm going to move on to Russell George, our Senate guest this afternoon.
Thank you, Chair. Just to pick up on an earlier point, there's quite a bit of discussion around the independent patient funding request. It's quite astonishing, isn't it, that within the English system wait a day, or the Welsh system wait a day, but across border you mentioned that it was several weeks a request could take. I think you said that unacceptable clinical risk. How does be really clear, how can that, in your opinion, how can that be overcome? In a nutshell, how do you overcome that?
On the same but slightly same sort of subject, better access to IT. So I had a patient contact me this week who'd been seen in England, but I had no correspondence. I had to chase that. The patient had to chase that. That's not right. So I think lack of knowledge, lack of sharing of IT is a problem. Another patient I had who is breathless. The problem is not respiratory, the problem is cardiac. They have a cardiologist across the border in Chester. They can't remember their name. I can't find out who they are. I have to contact their GP to ask, which is... So the lack of access to systems. I think in secondary care we may have different systems. Primary care, I understand you want to put them in line. But even if the system is different, access to different systems of local hospitals would be incredibly helpful. In terms of IPFRs, they're a bit... It's more patient specific, so that is difficult. I don't have an easy answer to that.
Does anybody else have an answer to that?
Not to the IPIs, but I agree completely with Ian. What patients tell us around what happens to them in terms of the digital interfaces is, in the majority of patients that I speak to want to have a single healthcare record, and I think if we have a single healthcare record and that it is digital for those that it'll work for, and we need to think about rural areas where maybe Wi-Fi is not as good, but patients talk about having to carry their information around with them. And then that's where a lot of the information gets lost, and you have healthcare professionals trying to chase down information. So I think that the kind of digital infrastructure getting strengthened between England and Wales will allow for requests to come through quicker, but I think that's also about having clear protocols and not just partnerships. It's about being quite clear about what those protocols look like.
And there needs to be a clear political drive to actually make this happen, because it is a clinical risk. If you can't get hold of results conveniently and quickly, it's a clinical risk to every individual patient. And
you say political will, so
there has to be.
What would your message be to both governments to make this happen?
Both governments have to make GP systems and hospital systems talk to each other, and hospital systems talk to GP systems, and ideally it all has to be in what they call a push way, so that the information automatically downloads from the hospital on discharge to the GP. GP referrals already go up automatically online, but that has to happen seamlessly, and there simply hasn't been a sufficient political will to do that, and every patient who's in that situation is at clinical risk.
It was clear it's a political will. That follows on to my next question quite well. So back in September, the Secretary of State for Wales announced a new partnership between the UK government and the Welsh government to drive down waiting times. So how do you analyse that statement, and what difference have you seen, if any, since that statement was made in September?
Waiting list?
Haven't seen a lot of difference.
Can't say I have.
Okay. So you've seen no correspondence either in terms of a statement from both governments saying we want to work more proactively together to drive down waiting times. You've seen no correspondence or information that's passed your desks in that regard?
No.
Not particularly.
Okay. And what, in terms of lessons that could be learned either way, is there lessons that the UK government can learn from what's happening in Wales, or the Welsh government can learn from what's happening over the border? What are the best examples, perhaps, from each?
I think it's fair to say that waiting lists by and large are shorter in England. We in Wales, I think, would argue that that's partly because of the Barnett formula. But the fact is that they are shorter. And in a United Kingdom, surely that can't be right. So I think we have to learn, and the two governments have to talk together, and hopefully now they're the same political colour, they will do that more, because at the moment Welsh patients are being disadvantaged. I think the services you get in primary care are broadly similar, even though contracts are different. Your individual consultations are much the same. But in terms of waiting lists for hips, for gallbladders, for hernias, whatever, there's no doubt that it's longer in Wales. It's not as long as it is in Northern Ireland, but it's a lot longer in Wales than it is in England. So we have to learn that. We have to learn what's being done there. I and I suspect many in Wales would argue that part of that is purely about funding, about actually buying in sufficient capacity in hospitals, sufficient clinicians to actually provide that and drive it down. But there are probably efficiencies as well.
What are the efficiencies then?
I think choice helps. We don't have much choice at the moment in terms of referral, and if that were the case, there might be something, but it's capacity. I mean, we often argue we don't have a waiting list problem, we have a capacity problem. We have to put more capacity in to be able to treat people quicker. And at the moment, we're not doing that.
You talked about choice. So there's choice in England, not in Wales. Why is that? What's the thought process do you envisage of the Welsh government to not? I mean, there must be an unintended consequence of that. So there must be a reason why the Welsh government are.
I think the Welsh government feel it's more efficient to do that, and it depends on your view of competition, I guess. If you think that competition improves the breed, then you may find that having a number of choices will shorten waiting lists. If you think that actually doing the same thing 3 or 4 different times actually makes the whole service less efficient, then you may well feel that actually directing referrals to a particular spot may work better. And all of that is entirely predicated on whether or not, given the populations that you're serving, the funding is identical. I suspect that's too big a question for us here, but if it were, that would be the thing.
A lot to unpick. I'm going to bring in Llinos Medi.
Yeah, thank you. Just to follow on, I just wanted confirmation. So you've seen nothing following the announcements of the Secretary of State for Wales around cross-border working and how that actually can improve the experience for the patients and yourself as service. And also go on to, you did touch on the Barnett formula there, and actually the need for fairer funding to mitigate the issues that our demography face around poverty and all the health implications that comes with that. So would you say that first, there's two parts to my question, the funding part and actually the announcement that we thought could mean better cross-border working and might not be true? Or a fact even. Thank you.
I'll answer one issue on funding. So it creates a problem in that the funding model in Wales and England being different. So in England, we have patients who cross the border, go to a hospital, they have outpatients and procedures, and they come at a cost. And I think England is very good at billing Wales for that cost. When patients come from England into Wales, because we're a provider and commissioner, it's not so cost driven. So I think in some services they're good at recovering those costs. Others, the suspicion is that they're not. So there may be income going one way and not the other due to the funding models. Also, the difference in funding models does create problems. I was speaking to a colleague recently who does sleep medicine, and some of the newer tests are not something where you buy the kit, but you buy the test, which works well if you have a model in England where it's per test, but it doesn't work well in Wales because you have to try and get the kit, and the companies don't want to do that, so it makes it more difficult and may inhibit access to some different tests. So that funding model causes a problem. In terms of the waiting list question, hopefully it's coming, we just haven't noticed on the ground yet, but announcements we hear, but haven't noticed practically much difference. I'm not in a waiting list heavy specialty, but maybe there's just a bit of lag.
Not a problem. Thank you very much. We're going to move on to Simon Hall, please.
Thank you, Chair. I mean, it's always been my belief that most people, when they have a medical need, they're not that precious where that need is diagnosed, treated and cured. They just want to have it done as quickly as possible. And I think most people would also have an expectation of cross-border sharing of both best practice and also sharing where somebody has tried something innovative, it hasn't landed properly, lessons learned in order to avoid that duplication. I happen to serve as well on the Northern Ireland Affairs Committee, and we heard this morning, Chair, from Fleur Anderson, the Parliamentary Under Secretary of State, who really sort of heartened that our committee, where she was talking about, yes, of course, health is devolved, but a real determination being driven equally from Belfast and from Westminster to share best practice in health, to drive up standards, to improve the patient experience and to improve patient outcomes. And the impression that she gave as far as the Westminster government was concerned is that that was a vision which they saw being operational in all parts of the kingdom, because it's a national health service and people have a number of you have mentioned this, a sort of an equal expectation. I'm slightly worried, if I've heard you correctly, and please correct me if I've misheard you, that there doesn't seem to be that drive towards sharing best practice, learnings, mistakes made, don't repeat, between England and Wales, notwithstanding the point I think Dr. Bailey you made of now the commonality of colour in terms of both administrations?
I think that the desire to drive up standards is absolutely common across the 4 countries of the UK. I don't think there's any question of that, and I don't think there's any barrier to sharing best practice. I probably would take issue about people would be prepared to travel anywhere for slightly quicker care. I think if it was much, much quicker, that might be a difference. An awful lot of care people don't like going away from. I mean, Wales is a more sort of constrained country in many ways, and
I'm a Welshman, so yes,
we prefer to stay locally. And if you want to have your gallbladder done, you don't actually want to have it done 100 miles away where none of your family can see you. If you could have a hip done in 6 weeks somewhere away, and it was a year in Wales, then I would agree with you. So I think there are degrees of magnitude to that, and I think most people prefer to stay local if that's reasonable, and I think that's quite a big driver. In terms of commonality of standards, I think that's a professional issue, and I think we absolutely have to do that, and I think we do. I think we do that quite well. But in terms of whether people will be prepared to travel more, I think it depends on the condition, and it also depends on the variations. And unfortunately, at the moment, we're seeing some significant variations, although if you've served on the Northern Ireland one, you'll know that the variations between Northern Ireland and the rest of the UK are massively greater than they are anywhere else.
Yes, indeed.
What I would say is, in terms of showing good practice, that people are always keen to do that, especially when it's successful. So you will see, if you go to professional conferences, we did this. This is what worked.
This was more at the political level, at the commissioning level, at the design level, rather than the have you tried this new type of bandage because it's much better than the last one.
I think there is less of that. There's certainly a lot less of this didn't work, because people don't trumpet that very often.
Like sharing
I don't think people share that quite so much. So I think that's much less well done. But you do find, from a professional point of view, you do find out what people have done, and you will share best practice. So it happens certainly for the successes, probably not for the don't do it this ways.
Yeah, that's always the problem. Yeah. Did you have a?
I think one of the things that the healthcare system at every level could do an awful lot better at is learning from innovation and learning from where things have worked well and what hasn't worked so well. But where things haven't gone well, how do we learn if we have different systems for kind of the management of complaints? Because that's how we learn. We learn by mistakes. And I think if you look at some of the recommendations that have come out of a lot of the inquiries where things have gone wrong, a lot of those recommendations repeat themselves again and again. Yes. So I think we have to have a system that England and Wales, through the different parliamentary ombudsmen, are coming together and looking at those themes, especially when you have the percentage of people, I think that's much higher coming from Wales into England than the other way, so that we are able to do that learning at a local, at a place level, because that's really important from an inequalities point of view, from a local level, and then at a strategic government level.
Thank you,
Thank you very much. And very brief question from Andrew Ranger to finish, please.
Well, yeah, thank you. It was just to seek a little bit of clarification on a technical point. So we've talked about the choose and book system in England. If you had a Welsh patient being referred into England's secondary care, either from a Welsh GP or a Welsh residential patient, did they get access to that choose and book element, or is that more restricted by the GP has a relationship with a certain hospital or service?
From a primary care referral point, it depends on the commissioning body. So if it's a Welsh GP, they have to follow those Welsh rules. If it's an English resident, then those English residents are still entitled to choose and book. But if it's a Welsh resident, they have to follow the same rules. And if it's an if it's a Welsh person going to England, I think I'm correct in saying that they have to, they can, the English GP can still access choose and book. But it doesn't work the other way round. I'm just trying to get my head straight on this. It is technically a more difficult. GPs the GP is controlled by the health board. So if your patient is in England, you're in Wales as a GP, then you have to work to the Welsh rules. But the English patient, in terms of secondary care, is still entitled to be referred under chosen book, is my understanding. But so there's a clear difference between where you're resident.
Yeah.
I think if you're in England and you're a Welsh patient, I think you can still be referred. It only works one way, is my understanding,
I think
which is unfortunate.
If we can ask you, Dr. Bailey, if you'd like to write to the committee, if you want to see, maybe clarify for us, because obviously we're not as technical as you, it would be really helpful if you could write to the committee on that point.
Do that. Yes.
Thank you very much. And I just want to bring the session to an end now. And I want to say thank you to all three of our witnesses today for being so helpful and sharing your experience and being so open. It's been really, really helpful. We've got lots of notes here. Thank you so much for your time. I'll bring the session to a close. Order. Good afternoon and welcome to the second session of this afternoon's looking at cross-border healthcare, and it's great to have our three witnesses online with us this afternoon. My name's Ruth Jones, I'm still the Chair of the Welsh Affairs Select Committee, and we'd like to welcome Carol Shillabeer, Simon Whitehouse and Stacey Thomas, and I want to thank you on behalf of the committee for joining us this afternoon. We do have a lot to get through. We've only got 3/4 of an hour, and I know your time is precious, so please I'm making a request of the committee for brief questions questions and similarly brief and precise answers from the witnesses. Thank you very much. And I'm going to start with Jill German, please.
Thank you, Chair, and welcome everybody. Good to see you all. Familiar face there with Carol, so nice to see you in Parliament, albeit virtually. So we were talking earlier in the session today about the announcement that the Secretary of State for Wales made back in September, so just 3 months ago, about how the two governments will be working together more closely to bring down waiting lists, and she said that it would be the beginning of a new way of working that would help improve outcomes for both nations. So we know there's a willingness at government level. It's safe to say it's very early days, but I'm really interested from you in particular, Carol, because of your time at Powys teaching hospital and now I'm glad to say it in Betsi Cadwaladr, what your thoughts are on the current cross-border issues, because we will need a baseline to know what we need to improve. So if I could start with you, Carol, that'd be great. Thank you.
Yeah, thank you very much indeed. I'll check that you can hear me okay. And thank you for letting me join online. I'm really grateful. So I think the first thing to say is the NHS, whether in Wales or in England, has worked together for forever. And for very many communities across Wales, it is absolutely normal for them to access their healthcare in England and vice versa. So I wanted to start with that because the sense of having new relationships, of course, for me is an extension of relationships that already exist, and that's really important. Clearly, there's been some divergence in health policy over time, and we're all dealing with the same challenges, but the way in which we deal with them will be different in our respective nations. As a health service chief exec, both in Powys and now more latterly in Betsi Cadwaladr, I've always looked across the border, and at times I felt that I've had a foot in England and worked in England anyway with colleagues such as Simon and others. And so this further strengthening of the collaboration is welcome. We have had a ministerial advisory group established, and just this week they visited us in North Wales. That was very helpful. That panel or group itself is made up of people who 50% of them are from Wales, 50% are from England. And the strength of the discussion led me to believe that we were going to be learning from each other. Now, there were clearly some feedback about the things that we can do perhaps differently that England have learnt. Happy to give a bit more detail of that. But whilst we, don't necessarily have the full detail of the new partnership, on the ground, the ministerial advisory group is a really strong start in terms of sharing best practice.
That's great, thank you. So the aim of those two governments is already feeding down into the commissioning stage, which is really good to know. So if I could turn to Stacey, if I may. So I'm interested in, we've talked a little about Carol's experience in two of the three authorities that are on the border, but then there's also obviously patients in Wales who live away from the border but may need more specialist treatments. So I wondered if you could just give us a brief outline of what the arrangements are for those patients to access those highly specialist treatments that are only available from an English provider. We're a small but mighty nation, so at times that really specialist provision will be over the border.
That is definitely true, and thank you again, likewise with Carol, for joining virtually today. Since the 1st of April 2024, we have set up, we are a new organisation, the Joint Commissioning Committee, on behalf of all of Wales, commissioning care for the patients of Wales. And in some cases, that will be for specialist cases that need to go over the border, but also where the flows or access to services need to be over the border into England for Welsh patients for a number of various reasons. particularly along sort of the border London providers. We also have a sort of financial arrangement where patients can access those services in a seamless way through a contract arrangement with us, and we do that with the joint commissioning committee as well. So in essence, I think we have around 37,000 patient contacts with NHS England. There'll be a little bit more that goes through sort of our IPFR panels for the highly specialist services, and we spend around 170 million collectively across the border for sort of those arrangements that goes through the JCC books. There will be more that health boards will spend locally, and patients that go through their services locally into English provider organisations. But broadly, it is around where access to specialist services is not available in Wales because of the economies of scale or because of the sustainability of services, or where there are rare diseases or highly specialised services. And we are the conduit really to allow patients to access those services seamlessly in England.
Do you feel that these arrangements as they exist satisfactorily meet the needs of Welsh patients, or are there improvements that could be made?
I mean, it's a really complex question, isn't it? When you think about commissioning more broadly, the thing from a public health perspective that we're obviously constantly looking at is what is the need of the population. We have got sort of our arrangements in Wales are around looking at that more broadly, and we have got, you know, sort of a national public health organisation that does look at that for us. Patients are accessing those services seamlessly. They are getting through to those English providers, and for those ones that need access to those care, they are receiving that treatment. So by and large, I would say the arrangements within the current systems are effective.
Great. Thank you, Stacey.
We just took evidence, from Dr. Stephen Kelly and on this specific issue, and he raised concerns about the variations between health boards and also in respect of type of specialist treatment that's available. So there are established pathways for certain treatments, but perhaps it's more complicated for others. And I think they talked about the dreaded IPFR. I'm just wondering, why is there such a difference between the evidence you're giving this committee as opposed to the evidence that we just heard from Dr. Stephen Kelly?
Yeah, perhaps it's helpful to put a little bit of perspective around it. So we said that there's around 37,000 patient counts that go across into the border. A lot of those will be for outpatients, as well as sort of individual patients accessing some, you know, expensive medical and drugs for their care. I think if we put into context what that means from an IPFR perspective for specialist services, we're probably receiving about 2,500 applications as a proportion of that, and around 200 that come through the IPFR sort of route. And if you think about how many of those are amongst those particularly on the border, by and large in context, we really are talking about sort of individual cases that are very individual, very complex in need, are specific and requirements that actually they do need a little bit of a look at, and we do need to make sure that the care and provision that they are wanting or requiring fits within policy, and we are by and large acting on sort of guidance that is provided by Welsh Government to us as health boards and Specialist Services Commission as well. Carol, I don't know if there's anything to add from a health board perspective on that.
No, I don't think so, Stacey. I think you've covered that. There are new and emergent rare diseases almost all of the time. We are very grateful to NICE, the National Institute of Clinical Excellence, that evaluate those, and we seek to implement those guidelines. And there are times when we are implementing those a little later due to setup. But thank you. Hope that helps.
Just quickly, Stacey. So you think the IPFR is fit for purpose, and Carol, you disagree with the evidence provided by Dr. Kelly that there isn't discrepancies between health boards in terms of how it's delivered in accessing specialist treatment across the border?
So the IPFR, the All Wales IPFR policy is under constant review, and like I said, it is a guidance that's provided to us that we have to enact through the direction of Welsh Government, if you like. the majority of cases, if not all of them, are being considered on an individual basis because of the individual nature of those cases that are coming through. So they are highly complex, and it is under constant review. And so it is a process, albeit a very complex one indeed.
And there's no and in terms of the treatment.
I think, Henry, I'm going to stop you there because I think the witnesses here haven't had the opportunity to hear the evidence that was given just now. So thank you very much for that. I'm going to move on now to Steve Witherden, please.
Thank you, Chair. If I may, I'd like to hear from the panel as a whole, starting with Carol, please. What do you hope to see from the UK and Welsh Government's new partnership to drive down NHS waiting lists on both sides of the border, announced by the Secretary of State in September?
Great, thank you very much for the question. Simply put, I'm hoping to see that we learn from each other what's working well, what not to try because it doesn't work. And then for all patients, whether they are in Wales or in England, that we can reduce the waiting times for treatments. That's a big focus at the moment, clearly, how long people are waiting. But there's some wider elements that I think we can learn from as well. So I know urgent and emergency care system has been very, very pressured over the winter period. What are we doing in Wales that colleagues in England can learn from, vice versa? And so that's really the main thrust of it is what practice is being brought forward, what innovation, what creative solutions are being tested, and how we share that with one another.
Thank you, Carol. Could I go to Stacey next, please?
Yeah, I mean, Carol summarised it quite fairly there. I think this is all about where can we learn and share best practice, how can we learn from each other, and how can we collaborate more effectively, particularly around where those services are more scarce in Wales, and really thinking about making that patient journey as seamless as we can possibly make it. I think there is something around data and for us in Wales learning about some of the one nation data dictionary that is available in England, and I think having some of those opportunities to benchmark, to share some of that will be really, really important to us.
Thank you. Simon, would you like to come in there?
Thank you, and thank you to colleagues for allowing me to join virtually, as both Carol and Stacey have said. So I would concur with the comments made by both Carol and Stacey. We've recently had the elective reform plan published, where the Department of Health and Social Care have set out their 4 main strands in terms of that. So I think we can share the learning from that and the work that's preparing to focus on bringing down the waiting lists across the themes of how do we empower our patients, how do we support the reform of delivery of the way that care is delivered, how do we make sure that care we deliver is in the right place, and how do we make sure that we've got the funding, performance and quality of delivery standards aligned. So I think there's absolutely some commonality in that space. I think it would be remiss of me not to say that we need to get better at how we share information and how our clinical systems talk to each other and share that information. So where we've got in the urgent and emergency care system, if we've got ambulance waiting, how do we make sure we understand properly both the clinical need and the time, whether that be a Wales ambulance or whether it be a West Midlands ambulance if it's outside one of our urgent and emergency care departments. I'm confident that the way the clinicians are working, that the patients are treated absolutely appropriately at that time, but having the data and sharing that information better will enable us to make sure that we plan in a more robust way for that demand and capacity piece.
Thank you. I had planned to ask what you feel the English NHS can learn from Wales and vice versa, but I do feel that you touched on that in some of the answers. So I'm going to leap straight to my most important question for my constituents. Do you think that greater cross-border working has the potential to cut waiting lists for Welsh patients?
I think my starting point would be we've got good relationships, and the principle of how we do any work is the basis of relationships and the individuals and people having those relationships. So whether that's with Carol, with Stacey, with other colleagues, then there's the basis of that relationship there. I think there are challenges in terms of funding, and there's challenges in terms of capacity, and there's challenges in terms of some of the differential policies and government mandate that's driving some of those different waiting times. I'm really clear that our clinical community want to deliver the right care to the right patient in the right time. And we need to bring waiting lists down across the board, and we need to do that in a way that's clinically based and managed well.
Thank you. And Carol, please.
Yes, thanks very much. So I think this is quite a complex one, because whilst we've talked about the learning, and I think we've made those points, when we're thinking about are we offering patients to go elsewhere, most patients would like to have as much care close to home as they can, but some will certainly travel, and we have been looking to offer those opportunities to people here in North Wales, both NHS but also non-NHS provider opportunities. Now, we have good, strong, long-term agreements in place between NHS bodies, and I've certainly been an advocate of looking to the NHS partners to see whether they have additional capacity to treat more patients, should patients choose that. If I just give an example of Robert Jones and Agnes Hunt Orthopaedic Hospital, very well used by the people of Mid Wales, but also well used by the people of Wrexham and Flintshire, and even further afield in North Wales. That is an English system, NHS body that we work very closely with. So we have these conversations about whether another provider has more capacity in order that we can make an offer to our residents. That is not always straightforward, because obviously colleagues are trying to meet the needs of patients in their own area. But we do have a collaboration that where an organisation can help, I have found they usually do. They want to help. So I think that's good. So there's no problem with will. There's probably more of a challenge around capacity, and that's a more difficult point to fully address.
Thank you. And finally to Stacey, please.
Yeah, I mean, I don't think there's much more to add really than what Carol have already suggested, but our relationships are strong. We have got really strong contracting relationships with NHS England, and definitely where we do lack capacity for certain specialties, then we look for all providers really to help us manage some of those ministerial targets and waiting lists. So nothing much more to add really than to what's already been added, but definitely a collective approach is always a step in the right direction.
Yeah, thank you, Chair.
Simon Hall, please.
Thank you, Chair. I think we all recognise that data is king in all of this. And I think most normal people out there put their head in their hands if they think that for them such a very core and basic thing about the ability of institutions to share data to improve outcomes isn't readily done and available. But we are where we are. That is understood. I just wonder if you could share with the committee the sense of urgency that drives that agenda, the timetable of delivery to which you are working, who takes the lead in that, and who effectively holds the pen or holds people's feet to the fire in order to ensure the delivery of that integrated data share, leading, not of itself, but playing a very key and pivotal part in improving outcomes for patients.
Would you want to speak?
Well, I don't mind. They can sort of toss a coin if they like, but I'd be interested to hear maybe from our commissioner first.
Yeah, so I'm sure you're aware that we have got the Digital Healthcare Wales organisation in NHS Wales that actually lead on all of our and are actually undertaking a huge task in sort of our data integration at the moment, and are working with NHS England and colleagues to be able to try to integrate some of those data and patient records to make some of those seamless transactions, as we've talked about earlier on in the session today. Timetable to delivery is always a bit of a challenge. In my humble, it is incredibly difficult. Our data architecture in both countries look different. Our data architecture in terms of governance changes quite regularly, and what we do need to do is think about our sort of infrastructure that supports all of that more broadly. So timescales.
I'm sorry to interject on that, Ms. Taylor. Those are hurdles, but they're not insurmountable hurdles. My general experience is that unless it may be missed, but unless some sort of deadline which can be, and a pathway which can be tracked is set, things often go into the slightly tricky in tray and never get the resolute attention that they actually require. Your answer hitherto is encouraging, but I wouldn't say it was confidence giving.
Yeah, and probably the challenges are real challenges, and I suppose leading into the part around the timescales is probably giving us some delay as to how quick we would actually want to get some of those, sort of Once for Wales digital programs up and running, and probably you would probably be better off posing the question to somebody from DHCW and getting an answer from them directly themselves. And obviously Welsh Government have a play in that too as part of their policy position. The other thing I would say is that just because that's not happening, it doesn't mean that we're not trying on an individual level, and we will, wherever possible, try to look at the data that is readily available to try and push to better integration to deliver patient outcomes. Carol, from a delivery perspective, shall I bring you in there?
Carol is itching to come in. She's almost leaping out of the screen at us. So,
Well, I'm delighted you asked the question because it gives me a chance to talk about what we're doing here. So perhaps I start with when I was in Powys, we did have cross-border challenges with the transfer of information between us as a provider and a commissioner into our colleagues, providers and commissioners across the border. So we did have that challenge, and we found ways to work around it. Not ideal, but we did. We a lot of hard work, not very much automation, I'm afraid. Where I am now in Betsi, Cadwaladr, I'm absolutely determined that we drive forward an electronic health record that helps the pathways of care, helps clinicians and others to do their job more effectively. And I've had some discussions with colleagues in the Northwest, where, of course, very many of our residents, our patients, go for parts of their pathway of care, about the potential for joining up. That is a challenge, a technology challenge, as well as an information governance challenge. But we're bringing forward an outline business case for an electronic health record. The Welsh Government have already invested, I'm delighted to say, in a mental health electronic health record. And we're busy procuring that, and then we'll be implementing it. So we will have gained a lot of experience, but it is one of the board's priorities, is to improve data and to improve the management of care through better records.
Thank you very much. I'm going to move on to Russell George, who is, I'm sure, very familiar to some of you, Chair of the Senate Health and Social Care Committee.
Thank you, Chair. In terms of your earlier questions in regards to the question about the Secretary of State's announcement in September for a closer partnership between the UK and Welsh Governments to drive down waiting times, you talked about your hopes about what that means. But have either of you received any correspondence or had any meetings or correspondence from the Secretary of State or Welsh Government ministers or the Chief Executive of NHS in terms of what that means, what's going to follow, and what arrangements might change?
I'm happy to start by saying I haven't had any direct correspondence from the Secretary of State, Welsh Government ministers, or the Director General in the Welsh Government. However, there have been conversations and discussions in a number of meetings about the potential for the Ministerial Advisory Group, as I mentioned earlier, as being the start of a relationship where we learn more about each other's practice. And certainly I'm very, very keen to take practice from anywhere, to be quite frank, whether in England or internationally, I don't mind, that will help deliver better care for patients. But no, I haven't had a formal correspondence on the detail of the partnership.
So was that sharing a good practice between Welsh NHS and NHS England not happening before then?
Yes, can I just mention something called GIRFT? I don't know if people know what GIRFT is. It's getting it right first time. We have had colleagues from GIRFT. It's a development initiative. It's fantastic, I must say. I'm a big fan of GIRFT. A whole host of clinical practice guidelines, new pathways, etc. And we have worked very closely with the GIRFT team in Wales. So some of that has happened already. This is about taking that to the next level. The lead for GIRFT, Professor Tim Briggs, was with us here in North Wales on Monday. He is a regular feature of some of our discussions about how we can improve our practice, where we can learn. So, for example, if I just say Llandudno Surgical Hub is under development here in North Wales. Some of that is modelled, and we took learning from developments in Devon, for example, and in London. So we do look beyond our own borders for innovative practice. And I know that colleagues on the MAG were looking at us about integrated health boards. What's the benefit of having everything sort of under one roof, so to speak? So I think there is that exchange, but no formal partnership paperwork as far as I'm aware anyway.
Thank you. I'm going to move on and I'm going to make a plea for very brief questions and brief answers. Steve Witherden, please.
Thank you, Chair. It's a question for Simon. I believe the area of Wales I represent is the only one that straddles two trusts. 65% of the constituency is covered by Powys Teaching Health Board. Now, something I've spoken about before is how Powys is in a unique position with no full-service hospital. So what arrangements for joint working does NHS Shropshire, Telford and Wrekin have with Powys Teaching Health Board to reflect this, and are they fit for purpose?
A really fair and valid question. So I think we need to look at this at a number of levels. So if we're looking at urgent and emergency care, there are really clear arrangements in place between the Shrewsbury and Telford Hospital NHS Trust and the Powys Health Board in terms of the management of that urgent and emergency care demand, and that's agreed directly with the provider in that space. Carol's already touched on the arrangements with Robert Jones and Agnes Hunt Orthopaedic Hospital when we talk about elective care and the management of elective demand and elective referrals through that. And we've already touched on, and you've previously heard evidence on, the challenges of some of the different governmental policies that sit behind that drive some of that variation in waiting list time and some of the capacity challenges that we've got there. From an integrated care board perspective, from a commissioner's perspective in England, we're really clear that we work closely with our provider trusts to make sure that we map and consider the demand and the capacity required from the residents from Wales to make sure that we understand the impact of that on any profiling of work and plans that we put in place for the providers within the England health system. I think your final point of the question was, are these fit for purpose? And I guess my point on that would be that the clinical drive to deliver the best care in the right place, I've not heard anybody say anything other than that's just a continued commitment to do the right thing by patients as and when they need to access healthcare. I think we've touched on the fact that there is more to do to make sure that patients are treated fairly and equitably in terms of waiting times for elective care.
David Chadwick, please.
Thank you, Chair. And another question for Simon about Powys Teaching Health Board. In your view, do proposals by Powys Teaching Health Board to extend the treatment time of Welsh patients being treated in hospitals in Shropshire and Herefordshire break the statement of values and principles that govern cross-border treatment, particularly where it lays out that different financial regimes on both sides of the border will not create barriers to patient care?
I think it's not appropriate for me to comment on whether it breaches the guidelines or not. I think what is appropriate for me to comment on is that we're in active dialogue with colleagues and the board in terms of the impact of any decisions that get taken. When we've met with providers as well. So we've had one conversation in terms of the impact of any decisions that get taken by the Health Board. We need to make sure we've got a collective responsibility that we use the taxpayers' money in the most appropriate way to benefit the residents that we serve and got responsibility for. I think one of the points that our providers articulated in those conversations was trying to run and manage a clinical service where you've got different rules and different responsibilities in that creates an administrative burden and is challenging when we want to make sure that we're treating people as quickly as possible.
Do you think it would be helpful for that statement of values to be transformed into a proper legal document to guarantee patient care for those living on the borders?
I repeat, I'm not avoiding the question at all in terms of this, but I think we've got a responsibility I've got a responsibility as a health commissioner to make sure that we're commissioning for the right outcomes for the population that we serve. We require government colleagues to be able to work with us to make sure that we've got the right policies around that to get the right outcomes in place for all the residents and the population that we serve.
Thank you. And I suppose I'm going to follow on with a question there to Simon. In terms of the fact that Wales and England measure things differently, so waiting lists, waiting times targets, performance targets get measured differently. Does this result in Welsh patients in England being on a separate waiting list to the English patients?
I would need to come back to the committee for the exact detail in terms of that, Chair, if that would be okay. But clearly we need to make sure that we are tracking and working to the commissioning rules that we get shared and get talked about and gets put in place in terms of that. And that was certainly part of the conversation we were having with Powys Health Board colleagues in terms of their consideration of the decision making around what that would mean in terms of clinical list management.
Thank you, Simon. That would be really helpful if you could come back. Thank you. I'm going to hand over to Russell George now.
Thank you, Chair. I think my understanding is there is no separate waiting list. So if a Welsh patient receives treatment over the border with an English provider, they are treated on the English waiting time targets. I think Carol's nodding to that. Of course, the issue here is that the proposal by Powys Health Board that's been referred to is Powys Health Board are proposing that isn't the case, because what they're effectively asking is that the same patient being seen in the same hospital by the same health professional could wait longer, depending on whether they're a Welsh or English patient. So I think the answer is, as far as I understand, I'm looking for your confirmation that doesn't happen now, but it would happen if Powys Health Board's proposal is brought forward. Have I got that right? Is that your understanding as well?
And I'll value Carol's opinion on this as well, but I apologize if I wasn't clear. So I think I was saying that with the proposals being put forward, we've absolutely talked about the additional burden that would create if we needed to move into a point where that was managed. What I didn't want to mislead the committee on was making sure that across, whether we're talking elective or whether we're talking urgent and emergency care and across all specialties, I would just want to make sure that I was completely robust across all areas. Carol?
Yeah, so just to be really clear, just because anyone isn't aware, that the standard sort of waiting time in England pre-pandemic, it feels a very long time ago, was 18 weeks, and in Wales, 95% of people within 26 weeks. When I was chief exec in Powys, we made no differentiation for patients that went across to England for their treatment, and that was the approach. Without commenting too much on Powys, because I haven't been there for almost 2 years now, clearly this is quite a tricky issue, and this is a situation, I think, knowing the Powys board, that will have been a very difficult area to explore, given the importance of the English providers to the Mid Wales population in particular. The vast majority of people in Powys will have had their treatments much sooner than the larger population of Wales, and as we know, it's a matter of record. England are currently looking at around the 65-week wait for the vast majority of their population, and Wales is at 104 weeks and above. So there's that differentiation to take into account as well. But I think it would be bringing something different to the table in terms of a differential here. But to remember that most of the Powys population, as far as I can see, do wait a much shorter time than people across the rest of Wales.
Thank you. Okay, I'm going to move on to Llynos Medi, please.
Diolch. Am pnawn da, Carol. This question is for you. Do Welsh health boards monitor the timeliness of treatments for their patients once referred to an English provider?
Pnawn da, thank you. Thanks very much. Lovely to see you. We do. It's very important. And when I made a reference earlier to data sharing across the border, particularly, when I was in Powys setting up some systems and processes to ensure that we could track through exactly what part of the pathway people were on, because they'll go for the first outpatients, then there'll be a diagnostic, etc., that we had to get a bit more into the detail of where in the pathway. That was particularly important as well for patients who are on the cancer pathway, because we really were trying to drive through earlier access to cancer, potential cancer consultations. So that is part of what we do. In North Wales, we're strengthening those processes. I think there's quite a bit of room for further development, and actually a bit more transparency on that for the population in our reports, so that people can see what the waiting times are if they are accessing care in England as opposed to here directly provided in North Wales.
Yeah.
Okay, thank you. And moving on to Ben.
Thank you, Chair, and thank you all for your attendance today. Can I first ask Ms Taylor a little bit about the contractual arrangements that the Joint Commissioning Committee currently has with English providers for commissioning tertiary care for Welsh patients, and quite simply, what is your assessment as to how well they work at the moment?
Yeah, I mean, you'll appreciate that depending on where the provider is in England will depend on how strong the interaction or relationship is. The further away we go from the Welsh border, the smaller the value of the contracted relationship actually is. We do have differential contracting sort of governance arrangements between the two nations. So we know that England has the one contract. We don't legally, we're not bound by that contract. And so there is some legal differentials between our systems that mean that we have to work through a different contracting model, through maybe a heads of terms or an SLA agreement or an LTA agreement. And as I say, depending on where the provider is, depends on the type of relationship that we have. The closer that they are to the border, and for some of our specialist services, particularly for Betsi, Cadwaladr as a health board, and Powys, we will have joint relationships with health boards where we have contracting arrangements between three-part type arrangements where we can have some of those conversations together, and then into London, then we sort of have some of those sole arrangements through an SLA, for example, for smaller values, if you like.
No, thank you. That's very interesting. And you mentioned the various ways of operating between different trusts. And I'm just wondering, is there a reason why it can't be more standardised and streamlined? Or is that a stupid question to be asking?
No, it's not. And to be fair, it's standardised wherever we can possibly make it. You'll know that English providers are bound by some of their local commissioners as well. So they've got a really complex arrangement between their local commissioning arrangements that already exist. And there are some things, just from a legal perspective, that Wales can't sign up to. And I know we've had a conversation about waiting lists, but not to rehearse that one. So there are differentials and approaches, and that's why we probably got to work similarly for Wales with England and England within itself. But that's why we've got to work slightly differently, if you like.
Yeah, and very briefly just on that, so I suppose that could be a scheme of work that the new cooperation between the two governments could look at, and I think somebody mentioned that the group has met very recently, and I wonder if this is something that could come under their work stream.
Well, I mean, we are very engaged in some of the cross-border activity. We sit on, we have medical directors that sit on clinical advisory groups, on rare disease groups, on specialist commissioning groups. We have cross-border contracting groups. So we speak very regularly and closely together. It is a piece of work. I think there's something about the true value that you get out of it in the economies of scale. I think there's something about making sure that we start commissioning on a value approach, which I know all nations are shared on, and really thinking about commissioning for outcomes, if you like, broadly going forward. And that's something I think would be really beneficial for us all to work on together.
Thank you, Priscilla. And finally, just to Ms Shillabeer, if I may, we heard from the first panel, actually, that there isn't a standard tariff prices for Welsh NHS organisations to charge their English counterparts when English patients receive treatment, particularly secondary care. In Wales. They mentioned that perhaps Welsh organisations aren't quite as on it to charging in those circumstances as the reverse case is true. Is this something that you're picking up in Betsi Cadwaladr, and does it cause a burden for you as a local health board?
I'm very conscious that the chair wanted brief answers, so I'll do my very best on this because it's quite complex. So we don't have the mechanisms that are in the English system, because back in 2009, the reforms in Wales led to the abolition of commissioner-provider split. So we don't have a tariff system or payment by results system that was more familiar in the English system. We do actually have things like programme budgeting, so we do understand what's all the costs that go into an episode of care, etc. That is not standardised necessarily across Wales. There are different levels of overheads that go in, etc., etc. And we are looking, Stacey mentioned value, we are looking really at value about how much things cost, what the experience is of the individual, the patients and the staff member, and then what are the outcomes? So did we fix what we needed to fix? So we're moving much more to a value-based healthcare system rather than a cost-only healthcare system here in Wales, and I'm sure that would be of interest to other colleagues in other nations as well. So yeah, hopefully that helps. So there is variation between different health boards.
Thank you. That's very, very useful.
Thank you very much, Ben. And I want to say thank you to the three witnesses in front of us today for the second panel. It's been very helpful. It's a very complex subject matter, and you've managed to condense it into 3/4 of an hour, so thank you very much for that. And I want to say thank you to Stacey Taylor, Carol Shillabeer and Simon Whitehouse, and I must now bring this session to a close. Order.